Now I invite Dr. Ramamurthy, and he requires no introduction. He has got a tremendous experience of using phakic IOLs, and he will be sharing his experience of on Indian phakic lens.
Thank you, Dr. Basin, for this kind invitation. It's always wonderful to participate in his excellent course, which offers a comprehensive coverage of phakic intraocular lenses. I'm going to be talking about Indian phakic intraocular lens, my experience. There is absolutely no financial interest. Basically, our practice now is about 50% ICL and 50% IPCL. We have also tried the other Indian phakic intraocular lenses, but purely because the relationship we use more of these IPCL, but the other alternatives that are also available. The approach to us as far as these phakic intraocular lens is concerned is very much like what we do as far as Indian and imported intraocular lenses are concerned. We do tell them that ICL is the first one off the block. It has certain considerations which makes there's a lot more experience with this. But if you cost is a consideration, which very often the case, because most patients require a bilateral toric implantation, and with a toric ICL, it becomes too expensive. So we do not want to deny this technology to our patients. So whenever it's necessary, we go ahead and counsel them and use both these lenses. So coming to the differences between these two current generation of these two lenses, the ICL generally, which is dispensed in BSS, corrects between plus 10 to minus 18 diopters, while the IPCL is available in a larger range of about plus 15 to minus 30. Again, astigmatism, there's a slightly higher range of correction that's possible with IPCL. This was one factor which kept me away from adapting these IPCLs a little earlier, because the collamer material, which is the most biocompatible material as far as the UV biocompatibility is concerned, is what the ICL is made of, or rather it's a hydrophilic lens with a collamer coating on top, while the IPCL is made of the conventional hydrophilic acrylic material, which our intraocular lenses are made. But in our past experience about using these lenses for the last 7 to 8 years, we have not found any incidence of excessive inflammation because of the material of the lens. The ICL per se comes with a central hole and two paracentral holes, and it's in the leading right haptic and the trailing left haptic. While on the other hand, the IPCL comes with it's a more holy lens, in the sense it has got a central hole, two para-optic holes which should be situated superiorly, and there are also 4 holes on the haptics of the lens. Because of these holes, neither of these lenses require a peripheral iodotomy. Currently, most phakic intraocular lenses that are available all come with a central hole, which is 360 microns to 400 microns in size. This has a 4 haptic pads. This has 6 haptic pads, and these 6 haptic pads, the company claims, offers better stability. To my mind, both these lenses are equally stable once rightly implanted in the eye. As far as the ICL is concerned, most often we use both these lenses a toric version, because we want to take care of any cylinder that is there. And this is often got to be dialed into place, say 15 degrees, 30 degrees. But the toric IPCL, since more customized, you can place it at 0, 180 degrees, which makes the surgery little easier. The size of the holes creating a central hole itself was controversial. Kimiya Shimizu first came up with this concept, and they determined that if you have a 360 micron, that does not have any visual dysphotopsia impact, and the IPCL has a 400 micron central hole. And the most important aspect that you need to understand if you're using both these holes, as far as implanting these lenses in the right way is concerned, in the ICL, it is in the leading right haptic and the trailing left haptic, you have these holes, and these are the indications. In the IPCL, all the haptics have these holes, so that doesn't really help. What you see is it's in the leading left haptic, you have this collar stud, and in the trailing right haptic, you have this collar stud. So you have to ensure that you understand this and make sure the lens opens up in the right way. And because the lens is dispensed in BSS, the ICL, basically it remains in the same size after implantation. IPCL, since it's dispensed in saline, it enlarges a little bit in the first 1 or 2 days, so that the ideal vaulting you can determine after about 2 days of the surgery. The loading in ICL is a little different, and earlier days we used to be told that if you have learned loading of this ICL properly, then 50% of the surgery is over. But today, my nursing personnel themselves very comfortably load these lenses, and in the IPCL is very similar to a plate haptic lens, and you just use saline to load these lenses. And as far as the optic size is concerned, it's slightly larger in a case of an IPCL, which obviously in these young myopic patients offers an advantage. The more important factor is that the IPCL being a local company, in case you come across highly mesopic size or scotopic size pupils, you can even custom make lenses of higher optical diameter without increasing the overall size of the lens. I already mentioned about these holes and haptics, so I'll skip that. Let's look at this video, and this is just the IPCL lens, because I'm supposed to be talking about the Indian lens. This is the collar stud I was talking about. This has to go to the leading left haptic, and this has to go to the trailing right haptic. And there is a central hole over here. All the haptics have those small holes, and there are 6 haptics in all, and there's also a central hole, and there is a paracentral hole. This is made up of hydrophilic acrylic material, extremely pliable, dispensed in a sachet of saline, and subsequently it has to be taken up, loaded, and then implanted. One of the things that you would notice that I am not dilating these pupils at all, because all of us who have done thousands of cataract surgeries have occasionally had an experience when you have a sudden entry of the blade and the anterior capsule gets touched by it. Obviously, if we have nicked the anterior capsule, what we do is to include it in our capsular excess, though it's not something right. But in a case of a phakic intraocular lens, if that happens, that's the end of the case, because the patient is going sure to develop a cataract. So I want the protection of the iris to be there when I'm making the incisions, and that's the reason these young patients usually dilate extremely well. Usually you make the side ports at 3 o'clock and 9 o'clock meridian. All these surgeries are done with the surgeon sitting temporally, and it's a 3 millimeter incision that I make temporally, because we do not want any wound assisted implantation. This is a mixture of phenylephrine and xylocaine that's being injected. As you can see, it dramatically, the pupil dilates. And it is also cohesive viscoelastic that I'm using. For a long time, it was told... For a long time, it used to be said that you should not use cohesive viscoelastic in these cases. I'm sorry about that. Because dispersive viscoelastic was what was recommended. But once the centra flow came up, we have started using the cohesive viscoelastic. And as you will see here, I don't even go in with the irrigation aspiration cannula. As I go ahead and hydrate the incisions, it just flows out. And that's the lens is always injected in front of the pupillary margin, in front of the iris. Then subsequently, using this spatulated instrument, you go ahead and introduce it, tuck it in just under the pupillary margin. It's extremely easy maneuver. Once you have done a few cases, you can easily master this. This is exactly what I was talking about. As I'm just hydrating the incisions, you see the entire viscoelastic coming out, because the occurrence of cataract during surgery is supposed to be most often occurring because during the irrigation aspiration step of the surgery, when inadvertently the anterior capsule is touched. And when you are not entering the anterior chamber at all with the irrigation aspiration, and the entire viscoelastic flows out as a bolus, that makes it much more controlled. And there is also another way of implanting these lenses, and that's a hydroimplantation. And essentially, I make the side port incisions, no dilatation, and then subsequently injecting a phenylephrine with xylocaine, certain amount of dilatation. When I introduce the cohesive viscoelastic, then the pupil will dilate even further. And most often in these young patients, dilatation in spite of the pigmented iris is not really a challenge. And you can see that it is happening quite comfortably. And even if you have a 5.5 to 6 millimeter pupil, you can. That's just an irrigation cannula that's inside, and no viscoelastic has been introduced. And With this, I'm able to introduce the lens, just like many of us do a hydroimplantation of the intraocular lens. I actually have a Varion overlay which is not showing up on the videos because of some incompatibility issues. Almost 75 to 80% of the lenses that we use are toric implants, and then you can also position these lenses under the hydroimplantation itself. Having said that, I found that this gives me a little less control, and more often I'm using under cohesive viscoelastic today. But this is one other way of doing it. Of course, you might have seen several videos of the lenses being implanted under HPMC, which is what most surgeons do even today. So, as far as presbyopic phakic intraocular lenses are concerned, IPCL is available today as a trifocal lens. ICL has already come up with a version, the EDOF version of the lenses are available in Europe. They say it should be. Can I take a couple of minutes? It's awaited in India. Maybe in another 6 months or so, it will become available. That the IPCL is essentially a trifocal diffractive lens, and you have an add power of from 1.5 to 3.5. And when you implant a +3 diopter lens, you get about 2.1 diopters for near and 1.2 diopters for intermediate. So even if the patient is just about 42, 43, we implant a +3 in one eye and +2.5 in other eye, because this lens has to serve the patient for the next 15, 20 years. Implanting just about a 1.5 or a 2 diopters will be quite inadequate, because what is labeled on the lens is actually the actual power in the lens, and what comes on the spectacles is significantly less, about 1/3 as far as the intermediate is concerned, about half as far as the 2/3 as far as the near is concerned. This is just the presbyopic IPCL implantation. The procedure is exactly the same. I just wanted to show you the diffractive rings. We have implanted about 50 of these lenses, analyzing results, and we'll be soon publishing it. But fortunately, we are concerned whether there will be significant amount of dysphotopsia. You can see those diffractive rings over there. But fortunately, that has not been the situation. And whenever the ICL is not in the proper position, you can always, all you need to do is to go in with the irrigation cannula, and just because I do not use any viscoelastic, with the digital overlay, you can exactly orient the lens where it should be. And this is very much doable with just a simple spatula, and you owe it to your patients to correct it in case it's not really in the right position. I think already Dr. Bhasin has dealt with this, but these are the IPCL sizing. The ICL comes in 0.5 millimeter steps, while this comes in steps of 0.25 millimeters. So it gives a little more option. Also, the fact that it comes from 11 to 14 millimeters. Exactly the question you asked, Dr. Suhas. You can see these patients operated about 5 years back. Right eye, the vault is just 117 microns. Left eye, the vault is just about 84 microns. And because the anterior capsule is pristine, we are not doing anything about it, but just following up. Similarly, a patient with 1,100 microns, but with this angle which is open, we are just following them up. That does not mean that we have to be careful of the fact that the angles don't zip up, and call them at least 3 to 6 months. This other eye, and you can see the fairly large vault in the slit lamp photograph also, and these patients can be followed up. But this is a patient who was developing crowding of the angles, and this is the way we exchange the lens, where again you can make a 3 millimeter, open up the initial incision itself, and all you need to do is to bring out one of the haptics out, and using a McPherson's forceps or the front loading forceps, go inside, use again a cohesive viscoelastic to form the chamber nicely, because both the ICL and IPCL was extremely pliable material. By just a hand over hand maneuver, you can bring the lens out. Sorry, somehow that step got edited out, but removing these lenses is quite easy. Then subsequently, you inject the lens. In this case, because for high vault, we actually reduced the size of the lens by about 0.5 millimeters, and then reduced it, and then implanted it. We have published on our experience with the these lenses, and the initial publication showed of 134 eyes analysis that is a safe and effective treatment modality for correction of myopia and myopic astigmatism. Then subsequently we did a comparative analysis where there was a cohort of patients, 119 patients who received IPCL, and 203 eyes which patients who received ICL. we found that there was a fairly large analysis, but then I'm not going to go into the details. Both worked equally effectively. So suffice it to say that phakic intraocular lenses has come to stay as an integral part of the armamentarium that's available to a refractive surgeon of the third millennium. And the availability of alternatives which are a little more economical obviously adds to the spectrum of patients for whom we can give the benefit of this technology. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy. It was a brilliant talk, including all your experience which you have given in your talk. And any questions from the audience? So you say that Indian lenses are the IPCL. You have an experience with IPCL, and another company also makes it
Even I've
bioacrylic.
implanted the biotech lenses also. I implanted the lenses which come from Appasamy.
Appasamy.
Yeah, those lenses are also equally good. Actually, some of my consultants like the biotech lenses. It's just a matter of practice, that's all. I mean, I think all these lenses, once you understand them well, works equally well. And very limited experience with the Appa lenses, just because we not use them many, but otherwise I'm sure they'll also work well.
Okay. There is no excessive development of cataract or iris shaping or reaction post-operatively.
I don't think I can comment on that because, our numbers are very small with those lenses.
Not with APA, but with IPCL
Yeah,
or
with the
bioacrylic.
IPCL, definitely the incidence of cataract is no higher than what you'd get with an ICL. And all the tenets that you very nicely elaborated needs to be observed even with these lenses.
Okay. The indications and the examination and the pre-operative assessment is same.
Absolutely the same. Absolutely the same.
Dr. Ramu, with regards to sizing of the lens, once you do your white-to-white measurements in the theater, do you have some other backups done in the diagnostic room with which you compare, and what's the kind of comparison you normally find?
It's a very relevant question in the sense that we do both with the digital calipers as was shown under the microscope, and then also we use either a topolizer or a OBSCAN to measure the white-to-white measurement. And ideally, both these measurements should be quite close to each other.
They're never same.
They're never the same. The reason we use both these instruments is that, obviously using a advanced equipment like a topolizer would be a good idea. But if you have a pigment or a blood vessel right at the limbus at 3 o'clock or a 9 o'clock meridian, that could give you a slightly larger measurement. So if these two measurements, and as was Dr. Bhasin was saying, you have to measure from mid-limbus to mid-limbus. And that's the reason you don't want to do it on the slit lamp or just with the patient lying down. Do it on the microscope with care. If there is a difference of more than 0.1 between the two measurements, I definitely ask for a re-measurements. And once it's done by an experienced, actually we have our optometrist doing it for us, we find that most often it corresponds. And in case you have to err on the side of you have to choose between the two measurements, we go for the slightly higher measurements because you don't want the lens to be sitting on the anterior capsule. A slightly larger vault is more acceptable than an extremely low vault. And generally we go with the instrumental measurements like the OBSCAN or the topolizer, because whatever we do digitally might be a little more erroneous, and that is subject to the person's variability of the person who is measuring it.
See, your lens star or IOL master also gives you a white-to-white.
No.
And also topolizer. So you would rely more on the topolizer.
No, I don't think you should use any biometer, optical biometer for doing this, because what you need is white-to-white. You need what all these instruments measure is sclera to sclera. That's the reason when you measure with the IOL master or a lens star, it will invariably give you about 0.3 to 0.5 millimeters higher.
Reading.
So that's the reason that you need to use a Scheimpflug instrument or a topographer to do the measurement and not rely upon a optical coherence. I mean, this
that's a good point.
laser interference biometry.
There's always a difference of 0.4.
Absolutely. It's well accepted, well documented, and you will find a difference.
Thank you, Dr. Ramamurthy.
So
I will.
one thing that I would like to add to this is I use the caliper, the digital caliper, and the IOL Master all the time, and that difference I keep in mind so that it is absolutely that. But taking the caliper reading as the gold standard means as the way to go forward,
Way to
because
go.
OBSCANs are no longer in use now, and we don't have an OBSCAN in whole of Calcutta at all.